every generation fights the same battles. There's no destination that is justice or that's a perfect place. And if you just hitch your wagon to the right person, they're going to get you there and settle it all for once and for all, right? If there is money to be made in people being less healthy, there are going to be interests want to do that. And I think you have to prepare for that contestation. And so I think if the mindset is, I'm going to go in and I'm going to achieve this policy victory and that'll be total victory and I'll done my bit, it's like, that's going to be discouraging, right? I think a different way to think about it is like, look, I've got a limited amount of time here on Earth. I've got to use that time in some way. Can I use it to try to make things better for the time that I'm here? There are going to be people who want different things, and some of those things are probably not going to be for the public interest, and there just have to be people who try to contest that.
What if the health inequities that we see today aren't flaws in our healthcare system, but rather reflections of a deeper societal injustice? Hey there, Health Feast listeners. Dr. Rock here. And in this episode of the Health Feast, Poe and I sit down with Dr. Seth Berkowitz. Seth is a physician, a researcher, and an expert in health equity and social policy. He's a primary care physician, and he's a voice advocating for a society where healthcare is a right, not a privilege. I had the good fortune of training with Seth years ago at San Francisco General, the large county hospital for San Francisco, where we both witnessed firsthand how patients, especially those the most vulnerable, struggled not because of lack of medical services, but because of social and economic barriers that were outside of the hospital walls. Seth is an associate professor of medicine at UNC Chapel Hill, and he's dedicated his career to examining the social determinants of health, food insecurity, and the power of medically tailored meals. That is, delivering food to people with chronic disease. He recently published his first book, Equal Care, where he digs into the economic, historical, and policy-driven roots of health disparities in the United States. And he aptly calls them a moral failure of society. Well, today on the podcast, we explore what health equity truly means and the systemic causes of health disparities and why quick fixes often fall short. We also dive into Seth's research on food as medicine and the promising steps forward, like Medicare coverage for medically tailored meals. Seth doesn't just diagnose our nation's healthcare issues, he offers a vision for a society that prioritizes health, justice, and access for all. So, whether you're on a walk, maybe you're on your commute home, maybe you're just unwinding at the end of the day, and you've been wanting to understand the bigger picture of health and health equity, this conversation with Seth Berkowitz is filled with insights, challenges, and a dose of hope for a better future. So let's do the show. Dr. Seth Berkowitz, welcome to the Health Feast.
Thanks so much. Excited to be here.
Exciting to have you here. I was telling Poe, of course, we introduce our guests before they come on, but I was telling Poe about how we trained together. Now seems like, wow, how many years ago? That was 15, 16, 17,
We're getting on. Yeah. When did we finish in 2010, 2011? So getting close to 15 years now.
Wow.
Yeah. So that's amazing. Poe, Seth and my wife were the same year. They were co-residents together and we were all in the same program. We had, I think training has changed drastically. Seth, would you agree?
Yeah, I think so. Probably mostly for the better, although, think there are wins and losses. But
well, because Seth and I would be in the hospital, in the ICU together, just the two of us, managing very, very sick people. We had the nurses there, of course. I don't know if nowadays residents have more supervision. Anyway, that was a crazy, insane experience. But one of the things, this was at the county hospital. This was at San Francisco General Hospital. In your book, your incredible, fascinating book, Equal Care, which I'm super excited to get into today,
you describe health inequity as a moral failure of society, which that, first of all, really impressed upon me, not just as a medical issue. I think we experienced that all the time when we would discharge people from the county hospital and we would discharge them to an SRO or, for a week, and they would come back and you could tell what we were doing was not addressing the underlying issue. I thought we'd start, Seth, by you maybe explaining for us, for our listeners, what is health inequity and how, and there's a lot of terms I think that people use and maybe misuse, like health equity, inequity, justice. So maybe you can give us a little bit of a primer for all of us.
Definitely. And yeah, I mean, I think a lot of, when we talk about the book, I think really does hark back to those days at San Francisco General and in our residency training more broadly. So happy to go over some terms. I'll preface it by saying, I'm not the language police. My goal in sort of talking about these terms is to be helpful and sort of clarify how to think about things, but it's not to say, use this term and not that term because I just like it for some reason. They're trying to make distinctions that are helpful thinking about the issue. And so to me, I think the simplest and most straightforward way to think through health inequity is to think of it as an injustice that harms health. If there's something that, is happening to someone unjustly and that winds up as a consequence harming their health, I think that's a health inequity. And therefore, I think the way to strive and work towards health equity is to find these injustices and get rid of them, to implement policies that treat people justly and provide the conditions that people need to be healthy. That, I think, is sort of the key piece there. I think a lot of times we think of health inequities in terms of, what I call in the book disparities or sort of a disparitarian mindset, which are differences in health outcomes between groups that you might attribute to differential treatment. And I do think that those disparities are injustices in many cases. There's no doubt, if you look at the difference in life expectancy by race and ethnicity in the US or, by various health outcomes by gender or other things like that, those are clearly result from injustice. But sometimes I do think that just focusing on the difference, the sort of gap between a group that's thought to be relatively well off and a group that's thought to be less well off is not as helpful for figuring out what actually caused that gap and is not as helpful for figuring out what policies we need to improve things. And so that's why I really like focusing on this sort of injustice frame definition, because it makes you think about, all right, well, specifically what caused this problem, or, it may not be just one thing, but what are the causes of this problem? If we implemented policies to address these causes, what would the effect of that be on health outcomes? So that's kind of what was trying to get at with using some of the terms in that way.
Give us an example of when using that disparity lens actually leads to worse health justice.
Yeah. So, I think the COVID pandemic, like many things in health equity, I think provides sort of a clear example here. There's an example in the book, and it uses sort of official statistics from the state of Michigan because they released a statement about their public health response to COVID in sort of the early days of the pandemic. And I won't get the numbers exactly right, but they basically said early in the pandemic, say April of 2020 or something like that, there was a big disparity in the mortality rates for people who are racialized as white and people racialized as black, with people racialized as black, much higher COVID mortality rates than people racialized as white. Definitely a result of injustice, no dispute there or anything. They then said, by September, that disparity had closed and the gap was much narrower than it was back in April. But what the statement doesn't really say is it closed because a lot more people racialized as white started dying. So both total deaths and the number of people affected in the population, both of those were much higher in September than they were in April. And so it basically was saying things started out bad for people who were racialized as black and then they got worse for everything else. But this isn't a health equity win in any meaningful sense, right? It's to the fact that that there is a gap or not doesn't necessarily tell you much about the causes. It doesn't tell you if that gap closes. Is that a good thing or a bad thing? Because it can close by, things getting better for one group or things getting worse for another group. And so to me, that was just an example of something that says, well, let's take a step back and think about what we're really trying to do here, which is have people not die from COVID and think about, what we might really need to do to make that happen.
That's other people getting worse is not good for the health of our society, and yet it eliminates the disparity. I think that is that's fascinating. Yeah, Poe, I'm curious. What do you make of this?
I was wondering if COVID sort of brought it to light more, or was that like under those circumstances, did that kind of make it more obvious or kind of like more concerning, or has it always been going on, but just never really, kind of looked at until COVID happened?
Yeah, I mean, so we've certainly had injustices harming health in the U.S. as long as there's been a U.S. So no doubt about that. But I do think that COVID really did shine a light on things. I think it was just so obvious what was going on. It was so clear that aspects of our response, and then also just aspects of the situations that people had been forced to live in pre-COVID would just put them at high risk during COVID. I think that really brought things to the fore. For example, there's this in the sort of labor economics field over the last, say roughly from 1980 to, around 2020, increasing attention to what's called, economic precarity. People who, instead of having, what we think of as kind of stable, good paying jobs, the kind of jobs that you might get with union support or something like that, where you've got health benefits, you've got security, you've got cost of living adjustment, your wages. People have kind of gig economy job, unstable jobs, having to work multiple jobs and things like that. So that precarity was kind of increasing, amongst workers throughout, the 80s, 90s, 2000s, 2010s. Then when COVID hits, clearly COVID didn't cause that precarity. That was pre-existing. But think about what it means to be, back in April 2020 or March 2020, if you're a worker in a precarious situation versus a worker in, a more well-paid situation. You don't have paid sick leave. If you're not working, you're not getting paid. If you are working, you might not be able to really mitigate and take all the precautions you can, but you got to go out and make a living and support your family. And so COVID kind of coincided with these pre-existing trends, and I think made things worse than they might otherwise have been for a lot of reasons. And so I do think COVID sort of not only shone a light on issues that affect health that were directly related to COVID, infections and things like that, but also just showed how the economic and social circumstances that people were in really impacted their health and their ability to sort of weather the pandemic in the same way that other people can.
Okay, so my question would be, like, what kind of advice would you give someone who is, like I say, let's talk about the workers out there that might be experiencing some issues with their care, or like particularly like if they go in a situation like, cause I was just talking to Rock before you came on. I was like, I don't think a lot of people really realize like that there is I'm just speaking to the people, the working class people that are like, they don't really know like the difference between what's good care versus bad care. They just know they need care. Right. And what would you say to that? How would you speak to people that are in that sort of population of people that are working class people that they might not even be aware that the type of care or the quality of their care is, compared to someone who has that sort of benefit? I don't know. I don't know if that makes sense. If that question makes sense.
Yeah, no, I mean, it's kind of one of those things of like, sometimes you don't know what you don't know. Right. And so, I mean, I think there are a couple of things there. I mean, so one I think is specific to the healthcare that people can access and the healthcare that people get when they do access. And there are real issues on both of those things. People often too frequently in the US are not able to access care when they need it. And then also there are certainly situations where people access care and it's not of the quality that we would want it to be. But I also think it's important to kind of take a step back and think about, the overall situations that put people in those things. And so what I think, could be very effective for working class folks and workers in general is, not only do we need to focus on maybe organizing our efforts and making sure that we can access care, not only do we need to focus on organizing our efforts and making sure that the care that we, can access is good quality care, i.e. say we get our employer to offer employer-sponsored health insurance when previously they couldn't, but it's restricted to a very narrow network of places that don't offer all the services people need or something like that. So those might be things to organize over. But also, what are the situations that we're just sort of in our daily lives that affect our need for care and things as well, right? Are our working conditions as safe as they could be, or do they put us at extra risk? Do we have a living wage that lets us afford the healthy food that we need, to not develop chronic illness in the first place, or to live in high quality housing, or to avoid, living in polluted environments or environmental conditions that worsen health, all of those things as well. And I do think a message that I tried to bring out in the book, which is a bit stepping away from my comfort zone as a physician, is that like, though we like to think that healthcare is kind of the key thing that matters to health, we actually know, and I think your podcast covers this a lot, that, it's really just the conditions in our daily lives that focus on healthcare or that create health a lot more. Yeah. And it's not so much healthcare. And in fact, by the time you need healthcare, it's almost a sign that things haven't gone as well as maybe they could have. And what we really need to be thinking about are the living conditions that people are in every day. And that might be, food and nutrition, which I know you all focus on a lot, but, and some of these other issues too, all of which are, potentially affected by workplace conditions and the ability of working class people to sort of, come together and mobilize and organize to, make clear what the issues are.
Seth, that resonates with us for sure. Poe and I have talked about that. I am part of a subgroup of the American College of Lifestyle Medicine that's called HEAL, and it's health equity achieved through lifestyle. And the central premise is that, your book, by the way, I was telling Poe, it's a health policy book. It's an economics book. It's a history book. It is a book, to say the least. Like, there's a lot of incredibly well researched and put together. Can you share a little bit about how did you get to this point where you're writing this book? What was it? I know we were in training and you were doing research on food insecurity and started your work on medically tailored meals. But what was it that kind of had driven you to study this and also work on changing this in our society?
Yeah, no, so, as you kind of alluded to at the beginning, it's been a long time since we're in training. And as you can tell by the gray in my beard now, kind of been at this for a while. And I think it felt like a very natural progression in a lot of ways. So, I've been interested in issues of health equity and health inequity for a long time, really going back to medical school and training and things like that. And you probably remember this too. The time of our training was one where, to me, it felt like just sort of incredible juxtaposition of, on one hand, just sort of how advanced and amazing biomedical technology is, right? You were seeing people in the hospital with, any organ that could be transplanted was being transplanted. We had, 5 or 6 floors of ICUs that were keeping people alive in situations that, even 10 or 15 years before would have been certain death. And it was just amazing, not just keeping people alive, but that, they got better and went back to normal lives. And you just thought about just how amazing all that stuff was, new blockbuster drugs coming out that made previously untreatable conditions, treatable and manageable and all that stuff. So like that medical technology was just, it was amazing to see that on a technical or sort of biomedical side. But at the same time, you'd go and do primary care clinic across the street from the hospital or at the general or something like that. And you had people who, their diabetes was uncontrolled because like they couldn't afford healthy food to eat, or their kids' asthma was acting up because they were living in, sort of damp and moldy housing. And just that juxtaposition of the amazing progress of biomedicine on one side, but also like feeling like we're not even getting some of the basics right. That was sort of what sort of launched me into this. But I'll say as a physician and, a clinician in sort of day-to-day practice, my initial thought was not, all right, well, we need to overhaul all of social policy, to do this. The initial thought was very much, can we do clinic-based interventions to, address some of these issues? Can we use things like medically tailored meals or food subsidies to provide healthy food for people to manage diabetes or some of these other things? And I think those are useful. And indeed, my day-to-day work as a researcher has over the last, 10 or 15 years has largely been about studying those kind of interventions. But it also just became increasingly more clear, which you said exactly earlier on, that like none of this was treating the causes of the problem. It was mitigating as best we could the consequences once they had already happened. But it wasn't, doing anything to say, well, why is a unhealthy diet so much more affordable or accessible to people than a healthy diet and all this stuff. And so as time went on, got more interested in these topics and then, just sort of spiraled out to there, right? It's like, all right, well, if I want to say something, have something meaningful to say about this, I need to learn a little economics. I need to learn a little policy. I need to learn a little history about how, this all developed. And then Poe, as you alluded to, I think the pandemic sort of really shone a spotlight on it here too. The other thing that the pandemic did is I think it sort of reset the stage for feasible change in some ways. And this may sound a little, but if you had said in say February of 2020 with, Trump in the White House with the divided Congress, I think Republicans in the Senate and Democrats control the House, or maybe vice versa, but divided Congress, said, all right, in the next 2 months, we're going to send out $1,400 stimulus checks to everybody in America. We're going to have the largest Medicaid expansion we've ever seen. We're going to have the most general unemployment insurance reform we've ever seen. People would have said, you're nuts. But all of that happened within 2 months, right? And that just kind of made me think, well, if you don't at least have your ideas out there and ready and available for when the moment comes, then it's just never going to happen. And I mean, who knows if it'll ever happen again. And I certainly hope there's not another pandemic on the scale of COVID or anything like that to happen. But it did just sort of make me think, all right, you can do this kind of day-to-day work of mitigating the consequences, but maybe you should also put a little time into, thinking a little more pie in the sky and say, all right, well, if we do get a chance to change things, what should we even aim for?
Yeah, you describe an egalitarian state. And when I was kind of reading that and learning about that, my first thought really went to Star Trek. And, this Federation of Planets the Earth has figured out their problems. We have moved beyond this capitalistic world. And we have, for example, technology in the Star Trek world. It's driven and used for social good and for exploration. So I'm wondering if you can talk a little bit about this egalitarian state. I love thinking about a hopeful future and how you write about it and what you mean by that.
Yeah, no, totally. So I think that's a great analogy with Star Trek, but I'll even say, I don't think we have to wait for, actually, I don't even know how far Star Trek in the future is at this point. We keep getting closer, but we don't have to wait for that. Like there's a lot that we could do right now. So the idea that the egalitarian state is this, I think broadly, kind of across the political spectrum, regardless of party, I think in general in the US, people accept or maybe at least pay lip service to the idea that all humans have sort of fundamental moral equality, that we're kind of equal in some sense. We might disagree about exactly what that sense is or what that means, but I think it would be rare to say now in the US, although it has not been rare historically, to say, well, this person is just, their life just should count for more than someone else. I think in general, we say that people are at least kind of born equal in some sense. That's a moral sense. I mean, that's sort of a sense of saying like, in the abstract, that's the case. But in our substantive lives, our day-to-day lives, there's very much the sense that like our lives are not equal, right? Some people get to do things that other people don't. Some people command many more resources than other people do. There are all kinds of hierarchies of status and privilege and other things that exist. The idea of the egalitarian state is that, if you're going to live in a democracy, if you're going to live in, a system of government that takes the idea of fundamental moral equality seriously, that's why we have democracy. The reason that everyone's voice should count is because everyone should count equally. That's sort of the whole justification. We don't have a king who counts for more than everyone else and gets to decide for everyone else. We all count equally and get to have some input onto that. And so if you're going to have that, then one of the fundamental jobs of the state, meaning government in that situation, is to translate this kind of moral equality into substantive equality, into equality in people's lives. If you're going to have a true democracy where you say everyone counts and everyone gets to participate, you need to put people in the situations where they can actually do that, right? And if you're starving, if you're unsheltered, if you are sick because you can't get medical care, then you can't really be sort of a full citizen in society and get to participate and have your say in everything. And so the idea is it just goes back to like, all right, what is the purpose of having government? What is it supposed to do? And I think one of the purposes that it's supposed to do is, to make sure that this moral equality gets translated into a substantive equality that people can all participate in the society equally. That doesn't mean there might not be, hierarchies in it, some circumstances. There's a great quote, I think, in the book from a economic historian, actually from like 1920s Britain. So it doesn't seem like it'd be super relevant to what's going on in the US right now, but actually, these issues crop up again and again. His point was that, political equality doesn't mean that every single person needs to be a senator, but there can be, kind of regular voters and leaders and things like that. But everyone needs to be able to have some kind of say in who gets to be a senator. And so if you don't have that, then you're not really living in a democratic society. The advantaged people are the ones who get to participate and make all the decisions and other people don't.
So I got a question. So what was the most challenging thing about care equality? Like, what's the most challenging thing after you've learned over the years and doing all your research? Like, what was the most challenging thing about it?
About like actually writing the book, or about what we'd actually need to do to move some of the things forward?
I would say a little bit of both. Actually, I want to know, like, just through your process, what was the most, like, that you can say now, like, yeah, that was pretty difficult. And then we'll move on to, like, as a society, what we need to do.
I mean, for me, I think, part of it was I just really did not have a lot of experience writing a book. I mean, so I am an academic, and so I write, journal articles and things like that, somewhat frequently, but those are like, 2,000 to 3,000 words, so maybe like 8-ish pages, 10-ish pages, something like that. They're usually about, some discrete project. So I do a research project and I write it up, and it's very formatted and standardized, and you get training to do that as part of your fellowship training and other things. Writing a book, I didn't really know anyone who had written a book. Some fields of academics, writing a book is like the key thing, but like I don't have a PhD. That's not like what my training was. And so just organizing something on the scale, I mean, I think the book wound up being around 300 pages of text, and there's references and other stuff as well, but something like that. And so just trying to stay organized was challenging. There was also that kind of thing where it's like, I don't know if you thought you were clear on something, and then someone asks you a question about it, or you go to try to explain it, and you're like, oh, maybe I don't understand this like as well as I thought, right? And it's like, unless you can like really explain something well to other people, maybe you aren't clear in your own mind. And so the book was definitely a big process of like working that out, where it's like, I thought I had a well-formed opinion on something or view on something, and then like as I actually like try to lay it out and explain it, I'm like, well, that actually doesn't make sense. Or actually, so I'd have to like go back and be like, well, actually, maybe I need to read a little more to like fill in this gap and all that stuff. And so organizing it all was definitely challenging, but that was actually also probably one of the more rewarding parts of writing the book, just because I feel like it helped me get clear in my own mind, like how to think about things and how to approach some of these problems too.
I'm curious, who was the target audience when you were writing this book?
So I describe the audience as like, what I'll call like a health equity practitioner, so to speak. So people who care about health equity, people who maybe, their work, maybe not 100% of their work, but their work is maybe at least in some ways engaged with health equity or could have an effect on it in some way. But maybe they didn't get, all the training in all the different disciplines. Maybe they're still, maybe they're a graduate student or a master's student or something like that right now, still in training. Or maybe they're out in the real world, like doing things at their own organization, but haven't gotten as much training about how all the different pieces fit together and those kinds of things. And so I think people in healthcare definitely would be a good audience for it. I think people working at community-based organizations that are trying to improve health or help people meet transportation barriers or have healthier diets or better housing or all those kind of things. I think people in policy, both of the state government, but, federal government, local government as well. So I think there are just a lot of different people who are doing things in their day-to-day work that can influence health equity and social policy, but maybe didn't have everything put together kind of all in one place, which the book kind of tries to do.
Yeah. Okay. So many audiences because so many different topics that you delve into, and you really try to give the full story. So I hear you delved into so many things because the economics side was very, very thorough. I would say universal basic income and things that I had heard about before, but I didn't know some countries or places have actually tried this or are doing this. Like we basically did it to some degree during COVID. So these are fascinating things. What have you learned through this process? I'm curious, that has sort of changed the way you actually, because you're a clinician too, you see patients every day and you're practicing in the current system, right? Like you're not practicing in an egalitarian state by any means. And so how has like this work changed and affected your practice? I'm so curious.
Yeah. So, I mean, I think for me, the main way to try to reconcile what the day-to-day, sort of living and working in situations that are not ideal with trying also to kind of make things better and march towards that ideal is just recognize that there are two different levels on which you can be operating, right? So in the day-to-day, you're faced with making a decision in the here and now, and you have to do the best you can under those circumstances. There's no escaping that. And there's no shame in saying, yeah, we're not in an ideal system. We're just going to have to make the best of it and do what we can there. So that kind of continues. But I do also think it's important to recognize, kind of where things fall short, why, and be at least attuned to opportunities to try to make things better when they come up. And so, you may have days or weeks or months where no opportunity comes up. You're just kind of, doing what you're doing in a given day. And it's helping people, no doubt, but maybe it's not, sort of advancing, a bigger picture solution or something like that. But sometimes, if that opportunity comes and you can have some influence there, you can do that too. And so I think it's important to have, both of those things in mind, but it certainly is no criticism to anyone to say, well, look, yeah, maybe this isn't exactly what you would choose, but you're just making the best that you can under the circumstances you're in. Who can do anything else other than that?
Yeah, Barack was mentioning that you have done some research in like food. Can you kind of, food, medicine, all the different and tailored meals. Can you talk a little bit about that?
Yeah, sure. So this is actually, one of the main things I work on. So, your audience is probably familiar with this, but so food insecurity, uncertain access to the food needed for a healthy life is a sort of a major contributor to poor health in the U.S. In any given year, about 1 in 8 households in the U.S. experience food insecurity, and that tends to be a higher prevalence in people with chronic cardiometabolic disease. So people with diabetes, for example, that prevalence is maybe 1 in 6 or maybe even 1 in 4 in some years. So, substantially higher. And so a lot of my work is focused around, both understanding ways that harms health, which big picture wise, yes, obviously it harms health, like don't need a lot of research there, but understanding sort of the subtleties and the nuances and whatnot is important for designing interventions and then actually designing those interventions. And so some of the ways that you can support people who are experiencing food insecurity and the health impacts of that include medically tailored meals, which are meals delivered to people's homes. These are particularly useful for people who might have impairments in activities of daily living or things like that. So it's hard for them to get out and shop and cook for themselves. Man also have financial barriers to healthy eating. And so that's one approach. Other approaches include, sort of delivery of what are sometimes called medically tailored groceries. So healthy foods delivered that then people prepare into a meal themselves, or like, community supported agriculture subscription box or something along those lines. And then a third approach are things like food subsidies. So there you have, a benefit that is cash-like, i.e. you go out and like spend it, looking at prices and choosing what you would buy, but is maybe geared towards, nudging people towards, healthier choices and those kind of things for, produce and fruits and vegetables and those kind of things. And so there are a lot of different interventional approaches you can use in a lot of different disease conditions that you might study some of that stuff in. So does it improve diabetes management? Does it improve blood pressure management? Does it help people not need to go back to the hospital after they've had a hospital admission? And you can kind of build programs that use some of these elements that also, usually have a key component of diet and lifestyle and nutrition education and sort of help people make positive changes in those kinds of things as well. And so that's what a lot of my kind of day-to-day research has been around.
Yeah, I was telling Poe that, and correct me if I'm wrong, a lot of the work you've done and you've done with colleagues has been the reason for changes we've seen in the recent past, like Medicare now covering medically tailored meals for certain situations and conditions. And then I think you've also been involved with where you were involved or are involved with the White House Conference on Nutrition.
Yeah. So, I mean, I sort of feel, kind of right place, right time. I've been doing this work during a time where I think there's been increasing interest in it. And I think it's, been going on long enough now that we've started to see some really positive changes. A lot of state Medicaid programs now through something called 1115 waivers and other policy tools have made available various types of nutrition support interventions, sometimes called food as medicine interventions that I think have been really helpful and beneficial for a lot of people. In North Carolina, where I am, there's one. In California, where y'all are, there's one as well. A number of states at this point, Massachusetts and others. That's been really good. As you mentioned, the Biden administration convened the White House Conference on Hunger in 2022. It's the first time in 50 years. There'd been a White House conference explicitly on the role of nutrition and health in the U.S. So it was a really big undertaking there. And, I guess tooting my own horn a little bit, but some of the studies that I had worked on were some of the ones that were cited in the report that came out of that conference to, sort of support reorienting our healthcare system towards more food and nutrition. But of course, many other people did great studies as well that supported that as well. And there has been, a move now, particularly in Medicare Advantage programs where they offer nutrition benefits. And there's a bill that's still hung up in Congress, hopeful that it passes, that would allow piloting of medically tailored meals and other programs in traditional Medicare as well. I think it's probably coming. And then a lot of state health insurance exchanges, the sort of, the ACA plans and those kind of things, those plans will frequently offer sort of food and nutrition benefits as well, as part of a way to help people be healthier. So it's a very exciting time in terms of, just sort of initiatives in this area.
Hey, man, I just want to call out that you years ago went into medicine with these like idealized views and wanted to change the system and have dedicated your career to this research and that now changing the system. And how many people, and that process takes years. And so I just want to much respect for that patience and that grit and that determination, and you keep going. And you know what I'm saying, Poe? Like,
yeah, seriously.
There's luck and there's right place, right time, elements to these things as well. I mean, I think of it all you can do is kind of take your shot, right? I mean, so you can try to do the best you can each day. You can keep coming back to work and trying to push things forward, and maybe it'll hit and maybe it won't. You hope that the better you do it and the more effort you put into it and the higher quality you make it, the more likely it is to happen. But, we all know life isn't fair. That may not always be the way things work out. And this is all stuff that a lot of people are contributing to. I mean, there's no, sort of great person of history. It's a lot of people and everything. So I feel grateful to have been, at the time where I can kind of make a contribution to that.
So what is your take on healthcare today? Like, what are your thoughts on it and reform? Yeah. Like, I mean, you're part of the wheel right now that's trying to move things forward. So that's what's really cool about this. And like I said, I sort of second that with Rock, man. Much respect for your efforts. You know what I mean? So, but what is your thoughts on what's going on today?
I think we've seen good and bad. I think it's a bit of a mixed bag. I mean, I think we have seen increasing health insurance coverage for people over the last 15 years. The Affordable Care Act, which sort of spawned Obamacare and Medicaid expansion, kind of passed right at the start of my medical training. And so, we've seen that develop. 40 states, I think, something like that have expanded Medicaid at this point. There are, health insurance exchanges in all 50 states. We keep getting closer and closer to getting everyone covered, although it's stalled out. It's been a little plateaued for the last couple of years or so. So I think that's all to the good. Hopefully the rest of the states that haven't expanded Medicaid will. North Carolina, the state I live in, just expanded it finally last year. There are a few more states left. So, I hope that kind of marches on.
But Seth, you told us earlier that that's not actually what creates health.
Yeah, I think it's absolutely the case that the key determinants of what you might call population health, the level of health in society, and the distribution of health in society, who gets sick and who doesn't, is not primarily determined by healthcare. That said, the ability to get healthcare, capability for healthcare is extremely important for everyone. And, no one wants to be in the circumstance of getting sick and not being able to get healthcare. And so even while I think we absolutely need to understand the limitations for health equity, for population health of what universal health access would give us, and it won't give us everything that we want in terms of better population health, we still need to recognize that getting that access for everyone is really important, and that, something like 5 to 10% of the population doesn't have that access is a major injustice. But it's absolutely true that we should not overstate what, continuing to do that will do. But I do think it's been good that we've been getting closer to getting everyone covered.
I think, Seth, I want your opinion on this. I think it really is a misnomer that we call it healthcare. I think that's actually part of the problem because it's illness care, it's illness insurance. Generally speaking, I mean, we get vaccines and some screening, but like generally speaking, most of healthcare is paying for when you get sick. And the analogy I like to use now is the car insurance. Like your car insurance kicks in when you get into an accident or something. Not even if something breaks because of wear and tear. Health insurance is probably better in that sense. But for upkeep, for going for my oil change, if I have, the car insurance is not paying for that. Similarly, I think the responsibility of keeping someone healthy, do you think that's the responsibility of the health insurance company? They're selling a product that's called health insurance because they're not doing that right now, right? That's not the focus.
Yeah, no, I think you hit on something really important. And fundamentally, I think the answer to something that you hit on is that I actually don't think an insurance model is the right model to think about how to provide health care for everyone for exactly the reasons you say. I'm a primary care doctor. I probably do more prevention in my practice than most other medical specialties for sure. And even then, it's just as you say, it is still a small part of what I do is truly preventive care, trying to keep people healthy, prevent illness. Virtually all of it is, chronic disease management or managing acute flares of illness and that kind of thing. And the insurance model, just any kind of insurance model, I think works best in these situations where there's risk of some uncertain outcome, but it's not something that, people need routinely, right? So you have it if you're in that bad car accident and your car gets totaled or something like that, but you're not, expecting it for just the tires and the oil changes. Similarly, your homeowner's insurance. Yeah, if a tree crashes through your roof or something, like you've got it there, but it's not what's paying you, your utilities and sort of routine uptake. Thinking about health insurance, I actually think is the wrong way. I think a better model is thinking of it as like, public school, like elementary education, K through 12 education, or thinking of it as like a utility or something like that. So healthcare is stuff that everyone needs. It's not just these like catastrophic events, but there's at least some healthcare that everyone needs. And that I think should be facilitated in the same way that we think of, elementary school or something like that, right? Or your kids and my kids are around the same age. We're in the midst of these school days and everything. Paul, I don't know if you have kids in school as well, but so that model I think makes a lot more sense, where it's just like, yeah, we know everyone should probably get a checkup once a year, or at least periodically with, scheduled immunizations and cancer screenings and those kinds of things. That's not an insurance thing. That's just service that everyone needs. And we should come up with mechanisms to do that. So I think you're exactly right. And further to your point of like a private health insurer, yeah, I don't know that it makes a lot of sense to say that the responsibility of a private health insurer is to ensure population health. I think that's something that we might, want to approach in a societal way, in the same way we say, look, it's our, role as a society to ensure that kids get educated, when they're young. So I think that's probably a better model, really.
Before our call, I was talking to Rock about, I had a cousin that I got some family members that live in New Zealand. And we weren't talking about this particularly. He was just talking about how they have, universal health care out there. What are your thoughts on that? Do you think that's something that would work here? I know it was a big topic a few years back. I'm wondering if it's still a topic now.
It's a big question, Bo. Yeah.
Well, I'm sure you know a lot. Based on your research, you probably have a great opinion on this, because what you see and you actually practice, so it's like, I just want to know what your insight is on this.
Yeah, no, and it's funny that you bring up New Zealand. I actually had a friend from medical school who practiced in the U.S. for 10 years or something like that, and after the COVID pandemic, actually moved along with his family to practice in New Zealand because he was just like, just can't do it in the U.S. anymore. I don't like how they run things, and he looked into it and felt like New Zealand was just kind of doing things better. I think there are a couple parts of this to think in mind. So one is healthcare financing and access. And then separately is what you might call, it sounds a little weird to say it this way, but what you might call healthcare production. So the doctors and nurses who are actually like producing healthcare services in hospitals and other things. When people talk about universal healthcare, I think they often potentially conflate two things. One is there a public system that finances healthcare or ensures that everyone has healthcare access? So just kind of everyone is covered, everyone can see it. And then two is, should doctors and nurses and healthcare workers be public employees, i.e. employed by the government or something? And there's some places that do both. So England in particular, the National Health Service in England, inpatient hospitalizations and whatnot, those doctors are employed by the public. So it's a national health service. They're employed by the public. Everyone can access it. No fees at point of service for the most part. And that system absolutely can work. Other countries do it where there's, sort of universal healthcare coverage in that things are publicly financed, but the producers of healthcare, the hospitals, the doctors and nurses are still kind of private organizations. So Canada does it that way. I think New Zealand, to a larger extent, does it that way. Fundamentally, both of those systems can work, but they have different benefits and drawbacks. If you want to control spending on healthcare as tightly as possible, then the sort of National Health Service approach, where the physicians and everything are public employees, typically works best when you compare studies across the world, because you basically you just set a budget and that's what you spend and you can't really do it. And so in the US, the VA system is kind of like that. And there's just sort of a budget and that's what gets spent and you don't have more that you can spend. So for controlling healthcare costs, that works really well and it guarantees everyone access. And in general, countries that use these systems have very related outcomes overall, but still totally accepting, Rock, your point that, a lot of what determines health is not determined by healthcare. On the other hand, a system like what happens in Canada and some other countries where there's kind of universal coverage for everyone, but the producers of healthcare are not necessarily government employees. They're still private organizations doing that, probably leads to more healthcare availability and maybe more choice in healthcare and those kinds of things, but probably at the trade-off of spending more in general. So it's harder to constrain costs when you've got private producers that you just have to contract with and those kinds of things. And so basically, I think societies have to choose which of those two approaches they want to do. And it's basically based on, are you willing to spend a little bit more on healthcare or not? Fundamentally, though, what all of those things do is they guarantee that everyone can get healthcare and can get basically the same healthcare, which we do not currently have in the U.S. And so either of those two approaches, I think, would be better than the status quo in the U.S., if only because right now, we're essentially rationing our healthcare. There are a lot of people who just can't get the healthcare they need because of the way that we've organized healthcare access. And that I just think is not good. But there's a lot of room for debate about what the best way to provide healthcare to everyone is.
I'll give you this question. You could wave a magic wand. 10 years from now, what would our healthcare system look like? When I say healthcare, think about what maybe the health ecosystem is.
So specifically on the healthcare side, before taking a step back, I do think we should have a system of universal access for healthcare. And fundamentally, I don't think it makes sense to like be having to change your health insurer at all these different times. And you get one coverage when you're a kid, and then one coverage when you're employed, and then you switch jobs and you got another coverage, and then you retire and you get a third kind of, and all this. I think there should just be a single system that covers people for life. That way there's an incentive to really take care of people over the long term and not just say, hey, they're not going to be 2 years.
If there was an incentive for the insurance company because they knew that was going to be their long-term patient, there would be an incentive. I think the way the insurance industry works now is just like you said, somebody could change their job tomorrow. So they don't think about long-term costs because their customers aren't long-term many times. They think about very short-term spending, which is why we're stuck. Yeah.
So that's definitely a change I would make. I would be remiss to not mention sort of the healthcare quality piece. We know that within healthcare, a lot of times people are making decisions about what healthcare to offer based on, extraneous factors, right? People's race and ethnicity or their gender or things like that. And so people may get lower quality healthcare for reasons that they absolutely shouldn't, and so if I had a magic wand to make that go away, that would be high on the list of waves to do. So, those two pieces of healthcare I think are really important. I think making sure everyone can get the healthcare they need in a consistent way over their life course. And then I think making sure that the quality of healthcare that people get when they access healthcare is not determined by their race and ethnicity or their gender or other things. But to what you say, what are also some of the conditions that people need to be healthy overall? And so there, I think fundamentally, this is something I would spend a lot of time talking about in the book, is we need to think about what you might call the distributive institutions, the ways that we distribute financial resources, money, these kind of things in our country. And fundamentally, I think a lot of our problems in terms of population health, having low levels of population health, stem from the fact that we don't provide income support that's needed for a lot of people in the US. The way I kind of break that down, if you think about it in a, sort of a market-based economy like the US, which is not bad, and I'm not criticizing, there are a lot of advantages to that. But fundamentally, income gets distributed on the basis of your relation to economic production, right? So you can either work and get paid for your labor. You can own capital goods or land or, money that gets loaned out and get interest or dividends or rent or those kind of things for that. Money gets distributed in that way. And we think about it as just sort of the default normal way, get money. If you want money, you'll go out and work for it. But only about 50% of the US population is in a situation where that actually makes sense. And I know you guys aren't going to start trotting out the right-wing talking points, but the initial response that I think when people hear that is like, well, why are people so lazy? Shouldn't they go out and get a job? But this has nothing whatsoever to do with laziness or anything like that. It just has to do with like the demographics of the population. So in the US, about 40% of the population overall is either below the age of 18 or over the age 65. So they're either kids and we don't expect them to work, or they're at what we consider a retirement age. So just right off the bat, that's 40% of the US population. And so like go out and get a job is not the answer for kids who don't have enough income, right? I mean, it's like, that's just not going to happen. And then so the remaining population, what you might call the working age population, roughly age 18 to 65, about 1 in 6 of that, or 10% of the population overall, either has a work limiting disability or is a full-time student. So they're intending to work later, but are just getting training to be able to do that. They're currently unemployed, so they're looking for a job. They were working, they're going to work again, but they're just kind of between jobs temporarily. Or they're doing socially necessary caregiving, so they're raising kids or caring for loved ones, but they're just not being paid for it. So that's another like 10% of the population. So 40% are either kids or older adults. Another 10% are sort of working age adults, but, kind of good reasons, so to speak, not to work. And so when you have 50% of your population that is just not going to get an income from the market, then you need to have social policy that provides income for that. And we have that, but it's very incomplete. And the incompleteness in those policies, I think, causes a lot of problems. We have, Social Security, the Social Security Administration's Old Age and Survivors Insurance, OASI, which is kind of the standard Social Security checks that we think about. We have, a child tax credit and a child-related part of an earned income tax credit and like some ways to get benefits for children. We have disability income programs, SSDI, Social Security Disability Insurance, and SSI, Supplemental Security Income. We have these things. We have SNAP and things like that. So we have them, but we run them in ways that make them hard to access. The benefit levels are low. They don't reach a lot of people. And so that fundamentally, in terms of what I think we need to be healthier as a society, is we really need to think seriously about our programs that are meant to get income for the people that getting a job is not the answer for them.
That's so interesting. It's, first of all, what you said, that there's so many stereotypes or beliefs that this common phrase, the government's handing out money you have to work, and so this is a very different way of looking at society. I think this is actually getting at this egalitarian state that you're right about. One thing that really was fascinating that you wrote about was the social wealth fund. Can you describe that? I'd never heard this described, and I wonder if it's possible.
Yeah. So social wealth funds, I think, are a great idea. Definitely nothing I invented. The idea of it has been around for hundreds of years. They've been implemented for, 50 or more years. I think it doesn't get enough attention, but I think would be really useful. So the idea of a social wealth fund is just that a government can own assets. So just like, an individual might own a mutual fund or a, 401k retirement account or something like that. A government can own assets and then it can collect the income that those assets generate, and then it can distribute that income out. So we actually have one of these in the United States. It was the idea of a Republican governor of Alaska in the 1970s and early 80s. We basically said, hey, there are a lot of oil companies and other companies that do a lot of natural resource extraction that come into Alaska and, use these oil rights and other things. We should get a piece of that. And so they set it up based on ownership of some of these, public resources that then get used. That fund profits from the business or partially are paid into that fund. In any given year, that fund is invested and it earns a dividend and it's paid out. And so every year in Alaska in the spring, each resident of Alaska gets, roughly $1,000, $2,000. It varies a little bit based on the market returns. They get a dispersal based on that. It's called the Alaska Permanent Fund Dividend. And so they've had that since the mid 80s, so about 40 years at this point, works fine. The world leader in this is Norway. So they actually have a couple, they kind of have two big social wealth funds that, again, are passive owners of companies. They're not, going in and like telling companies how to run their business. They own stock in the companies. And when the companies do well, they get some of it, just like any investor. And the reason that I think that it's a really cool idea is because it speaks to this issue that you brought up before, this sort of handout idea, right? So in general, if you talk about income support programs, people say, well, you didn't work for that. That's a handout. Why should you get that? Why should you take that away from a taxpayer or someone who did work for it? But with the income that ownership generates, nobody works for that by definition, right? If you own an asset, and you get interest on your mutual fund or whatever else, you might have done the work to earn the income that you invested in the fund initially, but anything that fund makes, you didn't do any work for that, right? Or if your, parents worked and, you get an inheritance and you invest that inheritance, a trust fund kid or something like that, they didn't work for it. But we have no problem with people getting the interest income from those accounts and whatnot. They're, if you're wealthy, you can live off of, just sort of inherited wealth and never get a job or anything. And no one says like, oh, sorry, once your parent who founded the company dies, that now the public has to own it. No, you can give that to someone else and they can generate income from that. And so the social wealth fund, I think, is great because it like completely sidesteps this issue of people not working for what is provided, because all capital income by definition is income that people didn't work for. That's just what it is. That's why it's different from labor income. Labor income is the income that you work for. And so I think it would make a ton of sense to do this. We kind of partially do this in some ways with like, government pension funds. So, pension benefit, like the pension funds that government workers and other people have, you pay into it while you're working, but then that money sits in a fund. It gets invested by institutional investors. It earns a rate of return every year. And some of that rate of return is used to pay out the benefits when it comes to collecting everything. So we kind of do this in some places, but I think there's a lot more of a role for using social wealth funds to finance some of these programs that we could use to then support people who are not getting an adequate income now.
Oh, it's fascinating. There's that potential and these programs that could exist, but then there's the political reality. What do you see as like realistic changes that could happen in the United States in the near term? In your advocacy work, like how do you frame where you think things should progress?
Yeah. And I mean, I think this is another area where I think the pandemic really changed my thinking in a lot of ways. I mean, I would say I'm relatively pessimistic by personality. I definitely throughout, sort of grew up in kind of peak neoliberalism times. A lot of the idea was, well, you're never going to make this big systemic change. So just focus on helping out, one individual patient a little bit more or all those kind of things. And, I don't think that was bad advice to be told, and it may well be true. And it may be that there's not an opportunity for big change. But I think one thing that the pandemic should have reawoken us to is the fact that like big changes are possible. I mean, so if things come up, like big policies can be implemented, there can be big policy changes. And frankly, it could go in either way. Things can change for the better or they can change for the worse. And we need to be cognizant of that. And so again, I do think there's this element of just kind of like needing to be prepared and having an idea of like what we want if that opportunity emerges. The other thing though, that I do think just in terms of like pragmatic, practical progress, day-to-day things is I think we need to think about being a lot more organized in the way that we do things. And I'm as guilty of this as anyone, but in social media area and other things, there's this idea that like posting is praxis or something like that, right? It's like if you just express your opinion, like you're actually doing something about it. But like actually, change happens because people get together and do the boring work of going to meetings and bringing in new people and building organizations that are started in communities and branch out and get bigger and bigger. And that's when you can elect candidates that you want. That's when you can put pressure on the candidates who were elected, whether or not they were necessarily your choice. That's where you can bring people together in sort of a solidaristic way and say, look, this affects all of us and we can make things better. And I will say, I do think health, and this is, I think, part of why the work that y'all do on the podcast is so important. Health is something that I think people can unite over, right? I mean, there's a lot of stuff that divides us, right? We can think of race and ethnicity, we can think of gender, we can think of sexual identity, all these things as things that divide us. But like, we're all humans in relatively frail bodies. We all know that our health could fail us, that we might not be able to do the things that we do right now. And I do think that health, thinking about the conditions that people need to stay healthy and then thinking about the treatments that people might need if they become unhealthy is something that we can maybe unite over and say, look, this is just part of the human condition. And despite our differences in other areas, maybe we can work together to kind of improve health for people.
Amen. I hope so. I hope so. Paul and I go back and forth so much because, you see, on the one hand, you want to be optimistic. And I think what you're saying is so true is like, and that's why I wanted to call it out before. It's not just about talking about these things and being a loud bullhorn, although that can be helpful, but it's also doing the kind of policy work, the behind the scenes work, having meetings, having, as you said, going to the boring meetings. You said it, I didn't. And so that work takes time. On the day-to-day, though, as we're practicing as doctors, you can agree. And as we look at the health of our society, our health is getting worse. The rates of disease are going up. And there are very powerful interests and players who want to keep and, in fact, expand the status quo. And that, I think, it can be frustrating. What I love about you, Seth, is that you're saying, well, we can be frustrated all we want, but we also have this lifetime to do something about it.
Yeah. No, I think that's right. And I mean, oh gosh, I'm blanking on the person who said this. This is not my quote, and I won't even quote it directly probably, but the sociologist, their quote was something like, every generation fights the same battles. There's no destination that is justice or that's a perfect place. And if you just hitch your wagon to the right person, they're going to get you there and settle it all for once and for all, right?
Even the Federation had the Klingons. Like something's going to come
exactly.
up.
It's always going to be contested. There are, if there is money to be made in people being less healthy, there are going to be interests want to do that. And I think you have to prepare for that contestation. And I mean, I think there can be real wins. You can achieve something and that's good and you should celebrate it and you need those wins to keep going. But I think there's never like an ending, right? It's like you never settle it once and for all. You never like vanquish all of these things. And so I think if the mindset is, oh, I'm going to go in and I'm going to achieve this policy victory and that'll be total victory and I'll have done my bit. It's like, that's going to be discouraging, right? I think a different way to think about it is like, look, I've got a limited amount of time here on Earth. I've got to use that time in some way. Can I use it to try to make things better for the time that I'm here? And, that can be better for my family. That can be better for myself. That can be better for society in general. Ideally, if you can, work on something that's doing all of those things, then I think you're in a really fortunate situation, but no shade if that, doesn't work out. But yeah, I mean, fundamentally, I think you just have to recognize that there are going to be people who want different things. And some of those things are probably not going to be for the public interest, and there just have to be people who try to contest that.
So I just had a question that came to me, and I don't know what your thoughts are on this, but like with technology moving forward, like AI, is there any like correlation between that and did the technology help this whole thing, or is it more like a kind of like a hindrance?
I mean, I think, and I have no special expertise about AI or anything, but I would say in general, I think of all of technological development as a tool that could help or hurt depending on how people choose to use it and deploy it, right? And so if it truly is the case that we can use AI to accomplish things that currently require, a lot of people and a lot of person hours to do now, and those people could spend their time in different ways that are more beneficial, that could be great. I mean, we think of the automobile or innovations in transportation as letting you cover more ground faster. And so people could use that time in different ways. But there have obviously been a lot of downsides to, use of fossil fuels and those kind of things based on the way it was put out. And there very conceivably could be a lot of downsides to the way AI gets employed if it just, allows, a small number of people to concentrate a lot of wealth, and then, leads to further social stratification and puts more and more people in conditions in which they aren't healthy, then that's not good. And so I think a lot of it will depend on just sort of how we deploy the tools, but there's probably no technology that is like always all good or always all bad. It just comes down to how the people who are fundamentally making decisions about how these things get implemented choose to do that.
Well, one question actually I want to have is a lot of this is policy work that takes time, sometimes work that we won't even see the public health effects maybe for years. But for our listeners or for people who just want to make a difference, either in their own life or the lives of their families, what can they do in moving towards health equity?
I would say just kind of be attuned to opportunities for change. I definitely think that, sort of big sweeping changes are unlikely to occur at all. And if they do occur, take a lot of time. But there are probably a lot of, kind of local or maybe sort of mid-level or state level opportunities for change that are just based on things that you see in your own community. You probably understand what are the injustices that people in your community are facing right now? What are big problems that are making people be less healthy? Are there things to do about it? And that probably won't be working alone. It'll probably be, joining up with other people, being part of an organization, organizing and working collectively towards this. But I would say just keep an eye open for those opportunities to make a difference. And remember, you're an expert in your own experience and the experience of people in the community that you're in. And so you're going to understand where those opportunities are better than anyone else can. And so I think if you have the motivation to want to make things better, you'll spot those opportunities and do it.
Seth, how do you do to keep yourself healthy? What are some of your practices?
Yeah, I mean, I think, we've talked about this before, but I think you and I are probably surely aligned on a lot of things. So I think diet is obviously really important. I've been a vegetarian for a while, which is definitely not the only way to be healthy. And in fact, you certainly can be a vegetarian who eats an unhealthy diet, depending on how you do it. But I do that, focusing on, whole foods, minimal processing, healthy fat, unrefined carbohydrates, lots of vegetables and fruits and that kind of stuff, I think is really, really important. All the stuff that you talk about and I learn a lot from. I think exercise is obviously really important. I ran, track and cross country in high school and college, and have always kind of had physical activity be a part of my life, which I think is important, and try to kind of instill on my kids as well. So I like to do a mix of, some more cardiovascular focused work and then some strength training work. Strength training is probably an area that I definitely underemphasized, because actually pictures from high school or college at that era, I probably weighed pounds and, couldn't bench just the bar. But, I think a mix of strength training and cardiovascular exercise is really important. And then I think the mental health aspect is really important as well. I think, being part of a community, having supportive family members, I'm fortunate to be in, a loving relationship and have a big extended family, have kids as well. So those are all, just blessings that I think are really important to me. Not people can create their own families and their own support systems. So you definitely don't have to do it in that way, but having some kind of support system and community, I think is really important. And I think just trying to keep your eye on the big picture as well. I mean, I think we all have, day-to-day frustrations, and it's not that everything goes well all the time. But I will say one thing about getting older, which, there's a lot of not great things about getting older, but one thing that has been pleasant is like, you've just kind of been around the block enough that like when things are bad, you maybe start to know a little bit more that like it's temporary and it'll pass, or you've just been like, yeah, I've kind of been through this before. And like, I am having a rough time now, but I know I have one of these rough times every couple of years and I kind of come through it. And so you get a little more perspective, in some sense as well. And so that's been helpful for me as well.
Man, yeah. Thanks for sharing that. I don't know, Rock, is this the moment question? So usually we always ask our guests on here, like, if you could give any life philosophy, any type of advice for our listeners, anything that helped you throughout your life. And it just sounds like, like what you're saying, perspective was like, that's a great way to put it. You're right. As I age, I do feel like it'll pass. I just got to get through it. But what kind of gifts and blessings and sayings could you give those of our listeners?
I would say in general, I'm a big believer in consistency, and I'm a big believer in just trying to get like a little bit better each day. And I think if you combine those, I mean, I guess we don't know how much time we'll have on Earth or anything like that. And so things could end, but if you have a relatively normal lifespan, or, have some time and things like that, I think just consistently trying to get a little bit better, do something a little bit better, improve yourself a little bit each day really does accumulate and kind of pay off in powerful ways. I think it's rare that there's going to be, some big break that, like flipping a switch, turns your life from, not the way you wanted it to the way you wanted it or anything like that. But I think it's common that you can make things better a little bit at a time. And over time, that really, I think, does pay off. So, you can use whatever analogy you want there, whether it's, continuously compounding interest in an account or anything else. But I mean, if you're just focusing on trying to get a little bit better each day, to do, whatever your work is as well as possible, to learn a little bit more or make a little bit of progress towards some goal, I do think over time that kind of pays off and the consistency is rewarded.
Yeah, man. Then you change policy.
Yeah. Yeah.
A little bit. Then you change the world. Oh, this is really cool, man. I mean, we keep in touch. It's been a few years since I saw you last, but yeah, you got to come out here, or maybe we got to come out there.
Yeah, we'll hopefully be out there this summer. Yeah, you guys will be welcome. Always have a place to stay, and North Carolina has great beaches and other things. So make a little family trip would be great.
And I love that I have been able to watch your career and all that you're doing in this world and all the changes that are coming about. I mean, sometimes I will, like when there was the White House conference on hunger, I would be reading an article and you were interviewed or quoted, and it'd be like, I know him. And like,
no, likewise, man. I think I love the stuff that you guys are doing. And, I think it's all about helping people to be healthier.
Cool, man. Thank you so much for coming on.
Yeah. Appreciate it. Yeah. And great meeting you, Pope.
All right. We do our customary fist bump.
Oh, yeah. Perfect.
To the camera.
All right.
All right. And that is The Health Feast. You can check us out at thehealthfeast.com. And until next time, live well and rock on, everybody.